Well, first of all, radium-223 is an important member of the therapeutic landscape in metastatic castration-resistant prostate cancer. It's specifically aimed at patients with bone metastases who have no visceral metastases and who have some form of symptoms. So it fits with patients who are metastatic castration-resistant disease with some bone metastases, some symptoms. It can come anywhere really in the treatment paradigm. So it can come first-line castrate-resistant, or indeed it can come after abiraterone, enzalutamide, or docetaxel, and it's also possible that these drugs can be used after radium-223. So it can actually fit anywhere in the metastatic castration-resistant landscape. Well, of all the drugs that I use in metastatic castration-resistant prostate cancer, it's got the least side effects. Most of the therapies, chemotherapy has quite significant toxicity potentially. The hormonal agents cause a lot of fatigue and many other problems. In fact, radium-223 for the patient is the one where they really don't feel they're having it at all. So there are some effects in the bone marrow. You can get low platelet counts, but it's a very minority of patients where that's a serious problem. A small minority of patients get some gastrointestinal upset, for example, some mild diarrhea. But for the most part, patients don't really feel any side effects, which is quite unusual in oncology actually. So from the patient experience point of view, it's the easiest drug. Yeah, there's a few reasons why that might be useful. Firstly, we like to get as many of the survival prolonging drugs in as possible. So the reason why radium-223 fits better earlier on is the patient is more likely to receive all 6 cycles, which is the licensed and proven dose for that drug. Secondly, the longer you wait with a patient with metastatic castration-resistant prostate cancer, the more likely they are to develop visceral metastases, for example, liver or lung metastases. So if you wait too long, it's likely the patient becomes ineligible to receive radium-223. So in general, it's better to use it earlier. Also, while the patient is well and they're not yet affected by their illness, it's nice to use a drug like radium-223 when it also has a good toxicity profile, so the patient remains well for longer. Well, the main mechanism of action is alpha particle irradiation. So it's ionizing radiation. The radiation is brought close to the tumor cells by the fact that radium itself acts like calcium. So when injected intravenously into a patient, the radium behaves like calcium and accumulates in the bones, and especially accumulates in the bones in areas where there are metastases. And as it sticks in the bone, the mineral part of the bone, it delivers a radioactive payload, which is alpha particle irradiation. And alpha particles are very powerful ionizing radiation that travel over a short distance, and like all ionizing radiation, they mostly carry out their effect by DNA damage. But the DNA damage experienced with alpha particle radiation is usually double strand breaks, which are difficult to repair. So it has direct effect on the tumor cells. It also has effect on the bone microenvironment, and we know that the alpha particle irradiation can also damage the osteoblast, and also inflammatory cells within the bone microenvironment. And it's quite likely that the effect on the bone microenvironment also contributes to some of the benefit of radium-223. Well, I'll start with the ADRAD trial. This is a trial that I run myself in Queen's University in Belfast. It's the only trial of radium-223 in patients with hormone-sensitive prostate cancer, so patients presenting with metastases in their bones at the time of diagnosis. The standard therapy for those men at the moment is ADT plus docetaxel if they're fit for that. The ADRAD trial is testing the combination of ADT, docetaxel, radium-223, and also external beam radiation to the prostate and pelvis area. So normally we don't irradiate the prostate in metastatic disease, but there's some good laboratory evidence to suggest that might be a good thing to do. And also, when the patient's responding to hormone therapy, their cancer burden will be at the lowest point in their whole illness. And then using ionizing radiation, both external and radium-223, we think there may be synergy there. So this is a 30-patient phase 1/2 trial. It's almost completed recruitment now, and the main endpoints will be toxicity. The ERA-223 study is a completed study now. It's a study which is in metastatic castration-resistant prostate cancer, and it's randomizing patients to abiraterone alone, so it's abiraterone plus prednisolone versus abiraterone plus prednisolone plus radium-223 versus placebo in the abiraterone patients. And it's really trying to test whether and adding radium-223 to abiraterone, which has already got proven, they both have proven survival benefit in this area, whether the combination has additional or synergistic benefits. The Peace 3 trial is a study combining radium-223 with enzalutamide, another of the life-prolonging ADT therapies, or advanced androgen therapies. So it's testing enzalutamide plus or minus radium-223. Again, primary endpoint overall survival, but the results of that trial will likely be another 2 years away or so. It's trying to test, is there a synergy between two effective agents with different modes of action?